We're gonna give you.
All right, we're just getting slowly started up again here. Everyone's finding their seats, and I think hope you can hear us online again. So this part of the afternoon, we're going to focus a little bit on narcolepsy, a very interesting condition. I'm actually going to co-present with my colleague here, Dr. Binjali. So I'll start the first part of the presentation. And just have no disclosures, so no conflicts of interest there. And so, well, I'll first talk about the clinical presentation for pediatric patients with narcolepsy, and then look a little bit at diagnostic criteria and how we test for this. My colleague, Dr. Binjali, will do the latter part of this, exploring the pathophysiology and epidemiology of narcolepsy and reviewing the treatment approaches. All right, and actually, this is very interesting because I just saw this kiddo last week. So very timely. Well, I first saw him several months ago when he presented as a 12-year-old, falling asleep everywhere, and particularly in class was the problem, obviously. So, you know, when I asked him, and what he was telling me is he reported times when he was unable to keep his head up and wasn't actually very clear in telling me, you know, was he just kind of falling asleep? There was times where he was saying, well, he wasn't sure if he was asleep or wasn't completely asleep. So that was a bit odd. He also had episodes of falling over and dropping things suddenly. So again, a little bit odd for a sleep problem to be having that in the daytime. And then he reports dropping objects, especially when his dad scared him or surprised him. And his dad had a habit of jump scaring him all the time. So I'm not going to get into their family dynamics too much, but that was also an interesting comment he made specifically. And he was unfortunately being bullied at school. And so that was another sort of prompt for the referral was school dysfunction and school issues. He was being bullied because of constantly falling asleep and falling over, but also being overweight. Unfortunately, very common with teens and young kids being bullied when they're overweight. He interestingly reported frequent and vivid nightmares. He could really describe these in a lot of detail. I'll get back to why that is interesting. And then he even reported having difficulty getting up in the morning and out of bed. And so the parents took that to be that he was lazy, he was tired, he couldn't get out of bed. But we'll come back to how that was also, you know, very interesting the way he said that. And so often, as is the case, a lot of these kids go through other teams and other referrals before they reach us as a sleep problem. Often this type of presentation is a very daytime-oriented presentation with dysfunction in the day. So sometimes sleep is not considered as the kind of first thing in the mind. So there were complex social dynamics. I mentioned the family dynamics were interesting, but there were also background issues with depression, anxiety, both in the family and in the child themselves. So he was part of and referred to psychiatry. They actually diagnosed him with conversion disorder, which is not uncommon for some of these kids going through this process. Of note, there were other psychological stressors, as I mentioned. He had also seen our neurology colleagues. And so, especially with these drop episodes, there was sort of a label of drop attacks. And when we say drop attacks in pediatrics or even in adults, I think there's a worry about seizures, you know, as associated with those. And he had been referred to a weight management clinic, not uncommon, obviously, for kids being overweight. And they emphasized or re-emphasized the message that he, you know, fatigue and sleepiness was probably related to his obesity to some extent. So these are all teams that had seen him before I did. And so, you know, we kind of did our assessment. We talked about the potential for narcolepsy. And so I'll mention, you know, we think of narcolepsy as this tetrad of symptoms. These are the kind of hallmark features. So excessive daytime sleepiness is one of the essential ones. And I should highlight in the sleep world, we, you know, talk about sleepiness different than fatigue. So both our colleagues, but our patients especially, they'll say, I feel sleepy. And what they actually mean is they feel fatigued, they're tired. So in sleep, the sleep world, we, you know, would say only use the word sleepiness when they're actually falling asleep, but colloquially we often, you know, use them synonymously. Cataplexy would be an obvious feature, although we'll talk about, and especially my colleague will talk about how that's not necessarily required for a diagnosis of narcolepsy. Hypnopompic and hypnagogic hallucinations. So that refers to hallucinations at the onset of sleep and at the offset of sleep or on waking. And then you heard from Kuntavai about sleep paralysis. This is also a very prominent feature in often presentations with narcolepsy. So I'd like to just return briefly to the clinical presentation I mentioned. So we talked about, times when he was unable to keep his head up, not specifically falling asleep, having episodes falling over and dropping suddenly, having episodes of dropping objects when his dad scared and surprised him. And so, I kind of rephrased a lot of the wording that was, on presentation, but you can kind of see that, those are actually episodes of cataplexy, and we'll talk about what cataplexy actually is. And then, the frequent and vivid nightmares, he actually reported those at the beginning of the night. And so it's very unusual, as Kuntavai had mentioned, nightmares tend to happen in the latter part of the night. And so what he was actually reporting were hypnopompic hallucinations, where they were mistaken for nightmares. And the reports of difficulty getting up in the morning and out of bed, there was a physical element to it, and that was actually sleep paralysis, which he, hadn't realized, or, unless someone is explaining these things to you or asking them in a certain way, you may mistake them as being lazy, not able to get out of bed because they're so tired, but he was actually paralyzed and not able to get out of bed. So when we talk about cataplexy, it's a word that I think is making its way more and more into, the sort of community language and narcolepsy especially. I mean, every med student I work with says at some point they think they have narcolepsy because they can fall asleep just like that, notwithstanding that they're, on call and post-call and overnight. So I think the sort of, terms narcolepsy and cataplexy are getting out there. Some people will, a lot of our patients, when you ask them, do you have cataplexy, they'll look at you, confused. And what is cataplexy? So, we define it as a sudden loss of muscle tone. And 80% of children with narcolepsy have cataplexy, although I should mention the numbers we pull out in narcolepsy are very much debated, because there's a lot of discussion of, which population have you pulled them out from? Is it just kids who are sleepy, just kids with narcolepsy? So we'll debate over those numbers potentially a little bit. Most commonly, we actually don't see those full narcolepsy drops. So we may get reports of things like eye and jaw and oral muscle drooping or weakness. And these are often kids labeled as making faces or acting funny or being misbehaving because they're making odd faces when they're actually losing tone in their face. So it's not as repetitive. It's more like an episodic weakness in their muscles as opposed to sort of twitchiness like a tic. So you could probably distinguish it that way. They are also triggered more so by extremes of emotion. So you might ask, if you hear a really funny joke, do you often have that happen? Or if someone really scares you or you're really stressed out? I mean, these are often the times you really don't want to lose tone in your body, but that's when these events can happen more commonly. At least during the cataplexy, as opposed to the falling asleep, consciousness should be preserved. So these are patients who are aware. They're fully dropped. If they have fully dropped, they're still aware of their surroundings, and they're highly variable in frequency. So it's very hard sometimes. They can go weeks or months without cataplexy. I've had patients tell me they avoid, funny jokes or they avoid social situations because they know it can trigger their cataplexy. And so if they haven't been told a good joke in a while, they might not have had an episode of cataplexy. So it can be very hard to kind of gather that history over, weeks, months, and even years. And so I wanted to show you a video. It may or may not work. Let's try it. All right. So let's see if I can play this. So this is a nice kind of situation of cataplexy.
Wake up, Sleepy! No, I'm still filming.
And I love this video because they're laughing and they're making fun of it. And so I'll stop it there. So it's very interesting. I mean, this is the humorous side of narcolepsy. But don't forget that if this happens on a school bus or on a subway train and it's late at night and you want to get off midway through, these are people who made it to the end of the line and they didn't get off their train. We have, kids going off to college where they may not be in a safe place when the cataplexy episode like this happens. So there's a very funny element to it, but this person is actually aware of everything going on around them. And I've also had kids tell me they were making fun of me. I could hear them, they thought I was asleep or I was passed out, but I could hear them making fun of me. And that obviously affects your mental health as well. I'll show you just a brief snippet of this
video as well, which can leave me quite vulnerable in certain situations, public transport, or if I'm by myself without a friend. So it impacts on everything I do, really, because you just have to think about things that somebody who didn't have narcolepsy wouldn't have to think about before doing something simple. Even something like going swimming. I don't go swimming anymore because there's a risk that I could have cataplexy.
I just wanted to highlight the picture first. So this one is a little less typical or maybe less stereotypical. You can see that it's more in her, face and neck, and she still has some tone in her trunk and body. So you might think this person is, if it was a kid, misbehaving or, acting funny, but she's, really struggling to try to keep some tone and use other muscles that haven't lost the tone to keep herself up. And you could hear her say things like, she can't go swimming. She has to be aware on public transport. So this can actually be quite, again, people think of it quite humorously, but could be very serious and life altering there. Perfect. So just to go in some of the other symptoms as well, I mentioned the hallucinations, and this is also where, we get often a overlap with psychiatry. These are kids that often do have comorbid psychiatric diagnoses, but their hallucinations might be mistaken as psychiatric disorders. And so, roughly half with narcolepsy will experience this. So there's no kind of single symptom that everybody will have aside from the sleepiness. Hypnopompic, as I said, is sleep onset, whereas hypnagogic is sleep onset, and hypnopompic is sleep offset or waking. And children often have a hard time distinguishing these from dreams and nightmares. So that's where, you get this really vivid report of a dream, and they do have vivid dreams as well. But usually the timing is what kind of helps us there somewhat. So beginning or end of the night. And then the other symptom we see commonly in narcolepsy in about 50% of children with narcolepsy is sleep paralysis. But as Kuntavai had mentioned, it's actually not that uncommon. Maybe I'll ask the audience, has anyone ever experienced sleep paralysis? There we go, yeah. So, technically they say about 30% of the population, although every time I poll the audience just randomly, it's not that many, but some people. And so that doesn't mean you have narcolepsy, for those out there who raise their hand, but it is kind of one of the potential tetrad of symptoms we look for. And just to keep in mind, again, consciousness is preserved, so they are awake and unable to move. And I've had some patients, when I explain this to them, you can see this weight lifted off their shoulders because they were so worried that something was wrong with them. They're aware, they're paralyzed, they can't move. And then they're fine after that, and people see them in the daytime and say, oh, it's all in your head, or, you look fine, you're walking fine, there's no neurological issue here. But that morning when they wake up, they are paralyzed and very scared of it. It can last anywhere from a few seconds to hours. Unusually, it's usually a minute or two. And, again, I mentioned frightening for the person as they are still conscious but unable to move.
Actually, the Chinese, they even have a phrase to describe that experience, like being crushed by a ghost.
Oh, okay. Just for the online audience, we had a comment that there's a Chinese phrase for this, specific Chinese phrase for this. It's interesting. And then, so there, associated features. So the other challenge, or as well, we have to think about when you care for kids with narcolepsy, is there's a high rate of comorbid disorders. We include nocturnal sleep fragmentation there. So that's a bit of a paradox. People think these are people who are so good at sleeping. They're so sleepy. They sleep everywhere. How can they have fragmented sleep? But actually the sleep they get is broken up. It's not very consolidated. And so paradoxically, they're really poor sleepers. REM behavior disorder was commented on as kind of dream enactment behavior, or more formally, we call this REM behavior disorder. And that's people acting out their dreams. And so, in REM sleep, we are supposed to be paralyzed. And these kids, have REM come into their wakefulness abnormally, and then in REM they have abnormal activation of their physiology and muscles. So they may actually act out their dream. We see more commonly as well periodic limb movements and restless leg syndrome. Obesity is a very common comorbidity. There's a bit of controversy or debate over cause and effect. It's probably bidirectional. And we do see earlier onset of narcolepsy in those who are already obese or tend to. Precocious puberty is also something more common in these children. So our endocrinology colleagues should be aware of this as well. And we share some Prader-Willi patients with them, which are also interesting with hypersomnolent disorders, but I'll leave that for another day. And then, as I mentioned, we do see a lot of comorbid psychological and psychiatric distress in these patients. So depression, anxiety, school stress, school performance issues. And then the differential diagnosis. So we were just talking about this, the query narcolepsy is the common referral as opposed to the fully confirmed diagnosis. So there's usually a lot of things that you need to go over first and think about before narcolepsy. EDS is excessive daytime sleepiness. So that's a very common symptom. A lot of our patients, although not as many pediatric, as we said, with sleep disorders, they're often hyperactive. But you'll get a lot of patients referred for sleepiness. Common things being common, you first want to make sure sleep hygiene is appropriate, their sleep habits are appropriate. And then relatively speaking, we would say, there's other more common sleep disorders like sleep disordered breathing and RLS and those kinds of things. Less so for kids, but still important, maybe more so in adults, reviewing their medications, where we're lucky kids are not usually prescribed lots and lots of medications, but especially with the psychiatric overlay, they may be on some confounding medications or issues. And we see lots of kids with seizure disorders as well, where anti-epileptic medications may cause sleepiness as well. Often the differential is around neurological issues. So they're especially the drop attacks or episodes of cataplexy. People talk about seizures as being on the main differential. But I've also shared patients with rheumatology where we're querying neurovasculitis. They need MRIs and lumbar punctures for CSF. So there can be that sort of on the differential with other symptoms that might prompt that. And then other health issues causing fatigue, also thinking as a generalist and broad-based kind of thing around fatigue. So, things like iron deficiency, hypothyroidism, obesity and deconditioning, these are all things that can contribute to fatigue in general. And then when there's cataplexy and other symptoms present, it does start to narrow the diagnosis. Some of these kids, it's kind of easy in retrospect. You look back and people say, oh yeah, the diagnosis of narcolepsy is obvious, but all of that's usually in retrospect. I should also mention, often these symptoms don't present all at once and in great frequency. The EDS is often the very sort of prominent symptom, and then you have to establish those other three symptoms I mentioned, but they may not be present. You don't need all of them there, and they may not be present right now. We do see evolving sort of phenotype over time, and especially young people with narcolepsy.
What are some of the examples of neurovasculitis?
Just as a broader condition, we have some of these patients with that are followed by rheumatology, for example, that have ANCA-associated vasculitis. Most of the time, it's very rare to get neurological involvement, but we're already talking about relatively rare conditions. So often these are kids who are seeing lots of specialists, and that might come up. Often they're reporting more things like headaches and seizures and such that would differentiate it from a neurovasculitis. And then your history is obviously very important. We use this Epworth Sleepiness Questionnaire, and there's lots of adaptations. I took this from a Medicare, questionnaire. I think they rate a score of 8 or more. I think it's some insurance thing. So there's arguments over where do you cut off your Epworth score in terms of how high it is. But we use usually somewhere between 10 and 12 as kind of abnormal sleepiness. And you can see this is the adult questionnaire. So it's adapted in kids. We usually will kind of modify some of the questions. For example, sitting quietly after a lunch without alcohol. Some parents get offended if I ask that question. So I usually leave that alcohol out. But with kids as well, we're a little less worried in a car while stopped for a few minutes in traffic. Often that has implications in adults who are actually driving. So, in this case, we take it as a passenger in a car, but if you're actually the driver, that can have, impacts as well and different implications. And then the diagnosis. So, we have the clinical criteria. Most of our sleep conditions, we follow the ICSD, which is the International Classification of Sleep Disorders, version 3 currently. And so they do mention that you do have to have daily periods of irrepressible need to sleep or daytime lapses for at least 3 months. So it shouldn't be something, acute or fluctuating. No better alternative diagnosis. We always teach residents, you can add that to any of your, short answer questions and be right. So always put that down, no better alternative. And then we use the sort of gold standard, although I would argue it's an imperfect standard, as we'll talk about in a second. But we use what's called the PSG, which is the overnight test you've heard about. But the daytime test is the MSLT, which is the multiple sleep latency test. And I'll talk about that a little bit more shortly. So we use this test to measure their mean sleep latency, so how quickly they fall asleep on average. And that should be less than 8 minutes generally. And then we use it as well. We keep all of the sleep set up on them so we can still see when they're going into REM sleep. And in the short nap periods, you should not be able to have REM come into your sleep, or at least frequently come into your sleep. And so we use this term SOREMs, which are sleep onset REM periods. And if you have 2 or more of those in the daytime test, then that's considered diagnostic for narcolepsy. And we generally do the PSG the night before. That's the recommendation, to ensure that there's no sleep disorder breathing, there's nothing the night before that could affect their next day nap test. And then there is auxiliary testing, not sort of formally or always considered part of the diagnostic criteria. There's genetic testing for a specific gene or HLA type, that's HLA-DQB1. We know that this is more common in patients with narcolepsy, but it is also present in healthy individuals. So again, not going to be diagnostic by itself. And then it's more so research not widely available as far as I'm aware, hypocretin levels in the CSF. And you'll hear shortly about the pathophysiology and why that relates to narcolepsy. But that can potentially be an adjunctive test or a helpful test. And I'll just sort of start to wrap up or get close to the end with talking about the multiple sleep latency test. And I just highlighted some of the parts there in red for maybe the technologists in the audience who are actually doing the test. So these are, requirements of the test. So the MSLT should consist of 5 nap trials. So we give the person the opportunity to nap 5 times in the daytime through the day. You can do 4 naps, and we won't go too far into that, but we'll say 5 naps. And then the initial trial should start, a couple of hours, 1.5 to 3 hours after the nocturnal sleep study. And then each subsequent trial should begin 2 hours after the start of the previous trial. So you're giving them these kind of very regimented, staged opportunities to nap. And then at the start of each trial, we give the instruction, please lie quietly, assume a comfortable position, keep your eyes closed, and allow yourself to fall asleep if you're tired or if you want to. And so this is kind of a different type of test where you're seeing how easily someone falls asleep. In comparison, we won't talk about it right now, but the MWT, which is the maintenance of wakefulness test, which is kind of the opposite. You're trying to stay awake. And I just highlight this because there are more specific requirements of the room, and you have to be off your devices. There's rules about caffeine intake and medication intake and all of that. But this is really an artificial kind of thing for these patients sometimes. Most of these patients will be using their phones and caffeine and devices and stimulation to try to stay awake. So it can actually be quite enlightening when you put them through this test. And then each nap trial is ended if the patient does not fall asleep in 20 minutes. So you give them 20 minutes opportunity, and then you do sort of 5 of those, and you will get an average sleep latency or sleep time from those. And then we have the whole polysomnograph set up on them, so you'll be able to stage their sleep and figure out if they're going into REM sleep. And this is actually the result that I reported last week on the kid that we saw. And so just to guide you here, these are the hypnograms. And so anything red means is a REM stage. In this, I think the stages on the side, they're a little blurry, but any red in the picture is REM sleep. And just to skip to the easy interpretation, instead of making you kind of pull out all the numbers, you can see the sleep was observed in 5 out of 5 naps with a mean sleep latency of 3.7 minutes and 5 sleep onset REM periods. So you can see that there's 5 red lines there. If you do the math from the table, you can see the latency was 3.7 minutes. So that's a pretty obvious result. He has at least 2 SOREMs in the study, and his sleep latency is less than 8 minutes. And just briefly, we talk about this MSLT as such a great test, and we just do have to be careful with all the confounders. And, often our patients are not just easily clean cut that this is just narcolepsy without anything else going on. We talk about a really low false positive rate generally. You'll say 2 to 4%. But again, going back to my comments about how we quote numbers in a lot of things, but especially narcolepsy, that's when you compare it to healthy controls. If you took a population, one study took a population of sleepy people, which is kind of our sleep clinics a lot of the time, and that had a false positive rate of 52%. So you have to kind of be careful when you say, oh yeah, this is obvious, this is narcolepsy from the MSLT, and that's a lifelong label often. We don't have a cure for narcolepsy. So when you give that label, sometimes I see kids, years down the road where we have to remove that label. And there was a lot of other stuff going on at the time. So you do want to be careful with that. And then the false negative rate is also of a concern. So often these are patients who are going through a lot. They've been through many specialists. Now they could have a really easy kind of clear explanation of their condition, and you get a negative test. And they may have all the other features. You were just thinking, oh, this is going to be the most obvious case. You have to worry about a false negative in a lot of these situations, or in some of these situations. So again, 5 to 10% overall. But if you look at some of the sort of situations we find ourselves in, it could be up to 20% false negative rate. So that can be challenging with kind of establishing a firm diagnosis, especially when you start to mix in that there are some patients without cataplexy. There are some patients on medications that suppress their REM, like antidepressants. And as I mentioned, in children especially, there may be a variation in the presentation. They may not have all the symptoms at the same time. And then we look at the MSLT, and it's based on normative data. I mean, I don't know. I think some of you in this room, if I gave you an MSLT, you might fall asleep in less than 8 minutes if you're particularly tired. And so we base that on sort of normative data of trials of populations. Most of the trials that we have or look at are 18 plus, although a lot of the adult data does include 12 plus year olds. So we generally feel pretty comfortable in that age range. There is some data, not as much, but some data in sort of 8 and over. But as soon as you start to get around that area, especially when you're going under 8, and there might be some kids who are still having daytime naps when they're 4 or 5 years old, kind of borderline, normal children having naps around that time potentially, it can be really challenging to kind of distinguish what a normal mean sleep latency is in these children. They shouldn't have sleep onset REM periods, but I mean, infants go in and out of sleep, so hopefully we're not trying to diagnose narcolepsy in a little baby, but there's a kind of spectrum of ease of, amount of REM sleep you get through your ages, ease of going in and out of REM sleep the younger you are. So it can be really challenging to establish what is a norm for especially the younger age groups. And so we do hope to kind of combine that assessment, not just use the MSLT blindly. Hopefully you kind of use your clinical assessment as well as suspicion with the results, and you sort of maybe need to repeat it, or we were just talking about, maybe you have to wean certain medications off to get a reliable result. So there may be several steps before you can kind of establish that even with the MSLT. And as I mentioned, we use sometimes HLA testing. Often these are not just clear-cut cases. So you're kind of building a case. You're trying to put together lots of pieces of the puzzle. And so HLA testing may be, normal, that phenotype, that subtype of HLA may be normal in a lot of people. But if you're combining that with a clinical picture, with an MSLT, it might sort of make you suspect that a lot more. And then, as I mentioned, CSF hypocretin can be really helpful in these unusual or atypical cases, but not widely available. All right, I think I'm going to stop there for my part. I'll invite my colleague up to take us through the rest of that. And I'll just mention, I really appreciate Dr. Binjali helping me out with this. So she is both seeing adults and kids, which we really value in the sleep community. It teaches us a lot of lessons from both sides. And so she does have a lot more expertise in treating narcolepsy than I do, as it's more common in adults. So I appreciate you taking us through the next part of this.
while we are doing setup, thank you so much, Kevan, for such a kind presentation of the introduction, I was going to say. So now, to digest the second part of this talk, and we will be talking about pathophysiology and the mechanism of action for medications, I propose we all stand up, and we do stretch. So I propose that we do stretch to the right, and then we do stretch to the left. Now we do roll with your shoulders. 3 rolls, direction you choose. Now we do a few motions of your head, and now you all can sit down, but don't relax, okay? So again, right now you overcome some of narcolepsy-like symptoms. And thank you for your cooperation. Yeah, I have my computer. Yep.
I think what we'll do is, while Dr. Quintaline will get your presentation up, if there's some questions at least about the presentation, and I